Thank you very much, Sandra, and thank you to the Endo-ERN for the opportunity to share our thoughts with you on endocrine and bone management in Duchenne muscular dystrophy. My name is Jared Wong from University of Glasgow. In my first 25 minutes of the talk, I will go through some of the issues relating to endocrine and bone consequences in glucocorticoid-treated people with Duchenne muscular dystrophy, aiming to cover a brief overview of DMD, issues relating to adrenal insufficiency, bone and osteoporosis, and delayed puberty. I will then be joined by Justus Carrier, where Justus from the Netherlands will share with you snippets of his life story and also some of his experiences with some of the issues that will be discussed in the talk. So thank you very much to Justus. So Duchenne's muscular dystrophy is a rare X-linked primary muscular dystrophy, although it is indeed the commonest muscular dystrophy, with an incidence of about 1 in 5,000 boys. The primary defect is a mutation in the dystrophin gene, leading to absent dystrophin, the protein, which acts as a shock absorber, which is required for maintenance of muscle of the stability of the sarcolemma. In the absence of dystrophin, a series of reparative events occur, which aims to try to maintain muscle stability, with resultant initial muscle inflammation. But subsequently, a series of events will lead to other pathophysiological hallmarks of the condition, like fatty infiltration of the muscle, and subsequently also to muscle fibrosis. Currently, there is still no curative therapy for Duchenne muscular dystrophy, but there are indeed some disease-modifying therapy. Prior to going on to therapy, I would like to just talk you through some of the other non-skeletal muscle consequences of Duchenne muscular dystrophy, which might be slightly less known. Brain involvement, i.e. neurocognitive involvement, is in fact actually fairly common. Dystrophin is indeed expressed in the brain, and we know that quite a proportion of boys and men with DMD have got aspects of autism, Asperger, ADHD, OCD, and a small proportion indeed do have significant learning difficulties. And a European project aiming to tease out more on the brain involvement of DMD is in place, and in years I'm sure we will find out a little bit more. Why is this important? Because this actually can impact on some of our endocrinology management of DMD, particularly when we come to testosterone therapy in a bit. We also interestingly note that other than growth impairment or severe growth impairment with glucocorticoid, which is expected, about 20% of boys with DMD, young boys with DMD, prior to institution of steroids are in fact short, under less than -2 standard deviation. The underlying etiology of short stature in boys with DMD prior to steroids is still unclear. Some older studies have looked into the growth hormone IGF-1 axis and have found no clear abnormalities. So this requires further study. Interestingly, in a fairly recent study from our group looking at DEXA images of bone length in steroid-treated boys with DMD in comparison with a group of healthy controls, demonstrate that in fact skeletal disproportion is evident in boys with DMD, such that these boys seem to have shorter leg length and also shorter distal bones. So it is unclear whether this relates to the underlying condition or steroid therapy, although to date there is no evidence of skeletal disproportion as in shorter leg length and shorter bones, distal bones, in other groups of children who are treated with steroids or in fact of pediatric Cushing's. So glucocorticoid therapy is certainly a standard of care and used as a disease-modifying therapy in Duchenne's muscular dystrophy. And its use has probably started much more widely since the early 2000s, but already have been used since the 90s. And there's certainly a lot of benefits of steroid therapy, it seems to prolong loss of ambulation by a few years. And there's now a much more recent study which shows that it maintains upper limb function and is certainly very important. And I'm sure we'll hear from Eustace in a bit about the importance of upper limb function. There is data to suggest that it also helps with cardio and respiratory protection and certainly reduces the need for surgical intervention for scoliosis, which is extremely common in DMD if untreated with steroids. And some suggested that it actually increases life expectancy as well. Steroids is used in such a fashion using daily prednisolone or daily prednisone with a starting dose of 0.75 milligrams per kilogram per day. In daily deflazacort, a steroid which is not very commonly used in any other conditions currently, at 0.9 milligrams per kilogram per day, either as daily regimen. Although the other regimen that seems to be fairly common, particularly in some countries, it is intermittent use of prednisolone at 0.75 milligrams per kilogram per day at 10 days on and 10 days off. So just to give an example of some starting doses of prednisolone, starting dose of prednisolone in a young boy with DMD around the age of 4 to 5 is about 10 to 15 milligrams of prednisolone, and with deflazacort, this is something around the region of 12 milligrams daily. There is some suggestion that daily steroids is much more beneficial for the muscle, and also some smaller studies which suggest that potentially daily deflazacort may be superior to prednisolone for muscle. But the definitive randomized control trial called the 4DMD international trial aims to compare these three common steroid regimens has been completed with results anticipated in the next year or so. And hopefully we will be able to find out more on the efficacy and also potentially some of the side effects of these three common steroid regimens. In the US, a different regimen seems to be used, although certainly a lot of us in Europe have little experience of this, and there's not that much literature on that. It's the use of high-dose weekend regimen of prednisolone or prednisone used in the US at 10 milligrams per kilogram at week, so much higher, but over the weekend. So there's also been a shift in pattern of use of steroids, such that previously steroids is used and perhaps discontinued at the time of loss of ambulation, but there's now an increasing trend of using steroids for much longer, well into adulthood, and I'm sure you'll hear about Eustace's experience. And why steroids used? There seems to be suggestion that in fact with steroid therapy, but also with better multidisciplinary care, cardio protection, and use of non-invasive ventilation or invasive ventilation where we needed, that in fact outcomes have improved over the years, with previously with loss of ambulation at around the age of 9, but now more in the teens, and mortality also improving. So certainly it does seem that steroids does play at least a part, or potentially a big part, in the improvement of healthcare outcomes in boys with DMD. But we do know that there are in fact numerous side effects, and today we're here to talk about some of the endocrine and bone side effects. As care of DMD, and particularly use of some medical therapies like steroids, have become much more common over the last 10 to 15 years. In 2010, the first international care consensus of DMD was published, and this was updated in 2018 with significant addition to some aspects of care, and in particular in the endocrine and bone care, a lot more issues have been added onto the care, and I will discuss that today. So first aspect I want to talk about is the aspects of adrenal insufficiency or adrenal suppression from the use of high-dose steroids. I think most of us, or all of us who are endocrinologists, will accept that using such high doses of glucocorticoid for more than a month, adrenal suppression will occur. These updated care consensus addresses the fact that a stress dose or an emergency plan needs to be in place, and it's crucial that the patient community is educated as early as possible, and that access to hydrocortisone as an injection during severe illness, or if the young person is unable to take that steroids by mouth, is necessary. Just to give you some ideas of the kind of dosage of steroids that's used in DMD and its relation to adrenal suppression, starting dose of prednisolone, as I mentioned, is in 0.75 milligrams per kilogram. But recently, in some of our work looking at fractures from the UK North Star database, that the average dose is only 0.5 milligrams per kilogram per day, which is approximately 60 milligrams per meter squared per day of hydrocortisone equivalent. Whereas in the daily deflazacort group, as you know, starting dose is 0.9 milligrams per kilogram per day, but in the real world UK data, it's only about 0.6 milligrams, but approximately 50 milligrams per meter squared per day. So one could say that perhaps at such doses that the dosing itself may be sufficient to cope with mild to moderate stress as they're in excess of the 20 or 30 milligrams per meter squared needed to cope with stress. But there are some issues to kind of think about, and I suppose this is just a nice table which actually shows you the steroid equivalents. Prednisone or prednisolone, as we know, is certainly from its inflammatory sort of bioequivalence, but four times the equivalent of hydrocortisone, with about 3.3 times of deflazacort to hydrocortisone. There's not very much information on deflazacort, but there's some concerns that its elimination half-life is relatively short. And there is some concern, certainly from some clinical teams, that the use of deflazacort, even though at such high doses, given administered once a day during mild to moderate stress, may not be sufficient, although there really is not very much research in this area. The issue of adrenal crisis and DMD, there's really just not very much information out there, but I just want to highlight a report on mortality from the northeast of England, published by colleagues in Newcastle, and also highlight an unfortunate case, and which led to the patient community working with clinicians to ensure that adrenal suppression is addressed in standards of care. In this paper from Dr. Gigleri's group in Newcastle, over a period of 10 years, 4 out of 21 young men with DMD died earlier. Of the 21 men, 4 were not related to cardiac and/or respiratory causes, and it's thought that perhaps 3 could be attributable to adrenal insufficiency. The picture here is a young man called PJ Nikolov, who is a late 20s man in DMD, who I think in the last 5 years unfortunately passed away. And what happened is that PJ was admitted to hospital with a fractured femur and underwent surgery where stress dosing was not given during surgery, and steroids was, I think, not actually administered a day after surgery. He also unfortunately developed fat embolism syndrome, which could have contributed to his demise as well, which I will address in a bit. But as a result of this, PJ's family have worked with the patient organizations in America and worldwide and clinicians to develop what we call the PJ Nikolov steroid protocol. And it's certainly a good recipe, but although I don't know, lots of clinical sites will also have their steroid stress dose recipe. But it really just highlights that this is an issue that needs attention, at least particularly for patient education. Next, I'd like to come and talk about bone and osteoporosis. And I think most of you will know that there is no doubt that the muscular dystrophy, or the immobility, or the poor muscle tone, and certainly steroid therapy used from the age of 4 and continued on an ongoing basis up to adulthood, is certainly osteotoxic. This really just figure tells you that there's at each stage of the age or developmental age of a boy with DMD or a man with DMD, there is progressive and irreversible insult to the skeletons. And in fact, these risk factors are relentless, and they become more and more of an issue. So at start, you might have some muscle inflammation, which we do know at least systemic inflammation does contribute to bone issues. And over time, there will be more use of glucocorticoids, there'll be vitamin D insufficiency. After several years of daily steroids, there's pretty much absent growth being very important for bone development in childhood, in addition to muscle development. We also know that obesity, which can be common in these young boys, could also add to the insult to the skeleton. And with delayed puberty and potential hypogonadism in some of these men, this certainly adds to that. One other factor, which is small, but I think it's worthwhile considering going forward, is that quite a lot of these boys and men are treated with proton pump inhibitors for gastritis as a result of long-term use of glucocorticoid, and there is some data to suggest that it might be related to fractures. So what are the consequences of osteoporosis and of the fragility fractures in DMD? The first long bone fracture in boys with DMD have been reported to be associated with premature and permanent loss of ambulation in about 40 to 50% of boys, and this is worthwhile knowing. Fat embolism syndrome, a rare condition as a result thought to be due to increased bone marrow fat in certain conditions, has been reported in DMD from fractures or even from just falls. So if a boy has a long bone fracture or a fall, and within the next day develops respiratory issues or neurological issues, certainly the consideration of fat embolism syndrome needs to be given. With vertebral fractures, significant back pain can obviously occur, but in some annoying and chronic back pain, which impairs quality of life, is also present. In postmenopausal women with severe and progressive osteoporosis, vertebral fractures, progressive kyphosis have been reported, and in some of those instances in postmenopausal women, restrictive lung disease has been reported, and whether this occurs in DMD is still unclear, but it's worth bearing in mind. What are the underlying bone defects in DMD? And certainly this is some work from Dr. Ward's group in Canada, which looks at bone histomorphometry in steroid-treated boys with DMD. And what the studies show that cortical width is only about 43% when compared to age and gender-matched mean. The bone volume over tissue volume is about 40%, and there's reduction in trabecular thickness and trabecular number. And structural formation parameters on bone histomorphometry indeed shows reduction in osteoblast surface of the bone surface. And dynamic turnover markers show reduction in bone formation turnover markers, but bone resorption was pretty much unchanged compared to age-matched control. So certainly we see a phenotype of thin bones, abnormal bone microstructure, with a low turnover state, particularly of bone formation. So bone histomorphometry certainly gives us a lot of information, but it's invasive. But certainly perhaps a high-resolution imaging using high-resolution MRI might actually give us some useful information on the muscle bone unit, and high-resolution MRI is certainly recognized and used in numerous clinical trials or in boys with DMD. You can see that on the left is a tibia, a femur, a slice of a healthy control and the boy with DMD, with lots of black showing lots of healthy skeletal muscle and very little fat infiltration. But with this boy with DMD, you can see that this is hardly much skeletal muscle at all, and there's extensive fatty infiltration. You can also see that there are differences in trabecular microstructure. And in comparison with an age-matched control, that boys with DMD have got smaller bones in the cortical bone and also thinner bones. And certainly it's this abnormal bone geometry and thin cortex which predisposes to the long bone fracture. So we can see these in detailed studies of the underlying skeletal or bone defect. But what happens with fractures? This is work done by Dr. Shuko Joseph, who's a newly appointed consultant neuromuscular clinician consultant in Glasgow, and worked during her PhD funded by the Chief Scientist Office Scotland, Muscular Dystrophy UK, and Action Duchenne. And what Shuko showed was that in 91 boys with DMD managed in Scotland from radiologically confirmed fractures, 48% at last assessment had at least one fracture, with 8% presenting with symptomatic vertebral fractures, with no vertebral fracture screening program during the time where this study occurred. Looking at the location of fracture, these are also different from the type of fractures that healthy adolescent boys sustain. Fracture femur, particularly of distal femur, is commonest, and you also see them in tibia and humerus. And 84% of these fracture episodes were classified as fragility fractures, as in they were all fractures from either standing or just from walking speed. And in fact, 23% of these episodes were fall from wheelchair. And I think wheelchair safety is still something that needs to be addressed. What about the differences in steroid regimen and its impact on fracture, which I already mentioned that there's certainly certain regimen that's used in our study using the Scottish cohort. We couldn't quite look at the differences because the numbers were relatively small in the different steroid regimen. Dr. Nicola Crabtree from Birmingham was able to compare steroid regimen between and fracture between two centres in the UK, with one centre using daily steroids and another centre only using intermittent steroids. And what you can see is that in the black bars and this left graph is the number of boys who became non-ambulant at each time point. And in black is boys on intermittent steroids, and in gray are boys on daily steroids. And you can see that looking just at muscle function, by 2 years follow-up, there's more of the boys, 10 out of the 25 boys were non-ambulant, whereas only 5 out of the 25 boys were non-ambulant at 2 years. But interestingly, using vertebral fracture assessment systematically in these two cohorts, you can see that there's also a difference between the number of boys with vertebral fractures at each time point, particularly at 1 year and 2 year. At 2 year, where you have 2 boys out of the 25 with vertebral fractures on intermittent steroids, but 10 out of 25 with vertebral fractures in the daily steroids. What this paper also showed that boys were on daily steroids were shorter and heavier at 2 years. So certainly there seems to be a difference between daily and intermittent steroids, which perhaps one could say is not that surprising. What about the differences between the steroid type, i.e. deflazacort and prednisolone, in terms of these endocrine and bone side effects? Previous studies have already shown that obesity or weight gain seems to be commoner in those treated with daily with prednisolone, and the short stature or growth failure is commoner in those treated with daily deflazacort. Dr. Shuko Joseph, using data from the UK North Star database, the large cohort of boys with DMD, in fact showed from these registry-based study that daily deflazacort is not only associated with the highest risk of growth failure with time, but fracture perhaps seems to be highest in this group as well. Although these are all preliminary registry-based studies and should be confirmed, but certainly the deflazacort itself, which perhaps was thought to be bone-sparing, may not be bone-sparing and may in fact actually have a greater risk of fractures. The studies by in our Scottish cohort and also the UK North Star cohort did not employ a systematic screening of the spine for vertebral fractures, and we know that if that is the case, vertebral fractures may be missed because results from the STOP study in Canada in different groups of chronic childhood disease, also treated with variable durations of steroid, showed that if you do not do vertebral fracture screening with systematic spine evaluation and rely on back pain, that you will miss quite a lot of vertebral fractures. The best group to compare with DMD, although not exactly identical, is children with acute lymphoblastic leukemia, who over the course of chemotherapy, from initiation of chemotherapy after diagnosis, are treated with variable lengths of steroids, although some of these steroids may be more toxic steroids like dexamethasone. You can see that in the STOP study, over 4 years of chemotherapy and glucocorticoid using systematic spine screening on an annual basis, 25% of children will develop vertebral fractures. And over the course of the follow-up, almost close to half of these vertebral fractures will be asymptomatic. So the message being that vertebral fractures are common in glucocorticoid-associated or glucocorticoid-induced osteoporosis, and that actually maybe about half of these vertebral fractures may be missed if we are relying purely on back pain. Identification of these vertebral fractures on spine imaging does require some degree of expertise, because spine imaging, lateral spine imaging, and reporting this is still quite variable, especially if it's read by people with not as much expertise and experience in looking at these spine images. It also requires grading into the severity of these fractures based on what is called the Ganant classification, which is based on the degree of compression and also based on the ratios of the differences between the anterior, the middle, and the posterior spine. And these are some of the grading. And I'll come back to this because the updated standards of care recommends treatment of vertebral fractures with bone protective therapies if there is evidence of moderate or severe vertebral fractures, regardless of whether there is back pain. And whilst spine radiographs or spine X-ray is conventionally used for identification of vertebral fractures, research group from various groups, including from Glasgow, from Birmingham, and Sheffield, have shown that some newer generation DEXAs may be of sufficient quality to allow identification of vertebral fractures similar to spine X-rays, and the usefulness of this is the much lower radiation dose if using lateral DEXA images as opposed to a spine radiograph, and certainly some centers are already incorporating this into routine care. So the recognition of the importance of vertebral fractures have led to the International Society of Clinical Densitometry to issue its first guidance around 2013 and updated in 2019 to state that the diagnosis of osteoporosis in young people should not be based on densitometry levels. So it's not densitometry dependent, but places importance on the identification of vertebral fractures, acknowledging that vertebral fractures is very uncommon as in young growing people, except in severe trauma. The decision to commence bone protective therapy in young people is therefore not densitometry dependent, because there are issues about which normative data you use, and particularly a threshold that predicts fracture is still not in existence in children with better relationship in adults. However, DEXA for bone monitoring is needed, particularly if bone protective therapies is used. So why screen for vertebral fractures in DMD? Because we believe it is common based on other groups of children treated with steroids. But the study also shows that if you do screen for vertebral fractures versus not screening and with allowing patients to present with back pain, that those who do not undergo routine spine imaging present much later with a longer duration of glucocorticoid, but with much lower spine volumetric BMD at the time of presentation, compared to those where routine annual screening of spine occurs, and the number of fractures per patient is also less. And importantly, in those where there's no routine spine imaging, significant and severe back pain is present in about 100%, whereas much more mild back pain is present in some people if there's routine spine imaging. So the rationale for vertebral fracture screening in DMD, as recommended in the 2018 standards of care, is because we do know also that the identification of vertebral fractures predicts future fractures, particularly new vertebral fractures in the future, i.e. what is known as the vertebral fracture cascade. We also know that spontaneous and complete vertebral reshaping of vertebral fractures without bone protective therapy can be seen in some childhood conditions treated with steroids, but not in DMD. And these are particularly in conditions where the insult to the skeleton can be minimized or in fact completely removed, like childhood leukemia, and where there's ample time for catch-up growth, and these are generally not possible in DMD. Whereas we do know that in a series of boys with DMD treated with bisphosphonate, incomplete or some reshaping of vertebral fractures may be possible with bisphosphonate therapy, and I'll talk about that next. So the updated standards of care recommends that intravenous bisphosphonate should be instituted, or discussion for institution, certainly if there's painful vertebral fractures, and that regular spine monitoring should occur in boys with DMD, and that even if there is the evidence of a moderate or Ganant 2 vertebral fracture without back pain, bisphosphonate should be considered, and also fragility long bone fractures. It recommends treatment for a period of 2 years on a more regular basis, and then perhaps at either lower dosing or less frequency till reaching adult maturity, although further treatment into adulthood should also be considered, although there's limited evidence. Endocrine and bone clinicians for monitoring of bisphosphonate therapy is useful. First dose acute side effects of bisphosphonate is fairly common and thought to be more severe in those with on steroid therapy, and therefore adequate fluid intake and consideration of stress dosing should be given. And longer term monitoring with therapy with DEXA is also needed. But it's also important that puberty is addressed, which will be my next section. So in the series from Canada, where 7 boys with DMD on steroids with evidence of clinically painful vertebral fracture, the use of bisphosphonate and with pamidronate and zoledronate improved back pain in all. There is some improvement in DEXA bone density such that change in DEXA BMD-Z score prior to the period of bisphosphonate is -2 SD, but it went up to about 0 to 0.5 SD, so not some improvement. On bone biopsies, there's stabilization of some of the structural parameters on histomorphometry. But whilst the majority do show, if you look at the figures, show improvement in vertebral fractures, and some show stabilization, new vertebral fractures in previously normal vertebra do seem to occur. A note to mention is that patient 1 seems to have shown a lot of improvement in vertebral height. But this again highlights the importance of removal of the insult and also the ability for catch-up growth, because this boy, in fact, actually stopped steroids therapy a few months prior to institution of bisphosphonate. So I think bisphosphonate therapy has got some role in stabilizing parameters, but I think removal of the insult and good catch-up growth is still important for reshaping of the vertebra. So just to go through some of the updated standards of care again, so clearly issues addressing vitamin D and calcium and monitoring of vitamin D is important, but it is this focus on lateral thoracolumbar spine imaging. 1 to 2 yearly on steroids and 2 to 3 year not on steroids is recommended, although this is not evidence-based, and perhaps research needs to clarify the adequate frequency of monitoring, and maybe this needs to differ depending on the steroid regimen. DEXA annually is recommended, but obviously prioritizing lateral spine images is DEXA is not available. And certainly the use of intravenous bisphosphonate, as I mentioned, but again, do not forget puberty. It is also important to involve a multidisciplinary team, and I feel that, in fact, the involvement of neuromuscular physio for fall prevention in the ambulant boys or those who are starting to lose ambulation, and also posture advice is also crucial. What happens for those boys who still fracture on bisphosphonate therapy? And one potential therapy, particularly in adults, that has been considered or can be considered is the use of teriparatide. Teriparatide or recombinant PTH is an anabolic bone agent. There's very limited study, and this very recent study from a group in America showed results of 6 boys with DMD who seem to have progression of fracture on oral bisphosphonate, which may not be as potent in this setting for DMD. Spine BMD-Z score seems to stabilize, but in all other sites there seems to be some deterioration. It may just attest to the longer duration of steroids and also the underlying myopathy, and that more boys lose ambulation over time. There appears to be a reduction in the rate of long bone fracture following use of teriparatide, but these boys are relatively old and a few lose ambulation over the course of treatment, and I think long bone fractures tends to be commoner in the ambulant boys and in those who are losing ambulation. So whether this truly reduces long bone fracture is still unclear. The need of research in the area of bone protection is something that the clinician and academics are interested in, but developing bone protective trials in this population is difficult. And in 2018, a group of us gathered in the Netherlands to try to tease out how we can do that, and I can refer you to the report which talks about how we might proceed with bone protective therapies. The last section is on puberty, and puberty is something that may not have been given as much attention in the past standards of care, and certainly not addressed. In our report in 91 boys in Scotland, about 30% were aged 14 years or older, and only half of them have had puberty examined, with the other half of not had puberty examined. And it may be that these ones where there are no clinical concerns. But of those where puberty was examined, about 80% of them were prepubertal, and at the last visit, the majority had gone on to receive testosterone therapy to address puberty. There is still limited information on pubertal abnormalities in DMD. There may be an impact on steroid, and I suspect those who are on daily steroids will almost universally have delayed puberty. Do beware of changes of glucocorticoid regimen in adolescence and dosing. We don't have that much information on the biochemical abnormalities, but it's thought perhaps this is an insult centrally at the level of the pituitary and hypothalamus. But in our clinical experience, there's certainly suggestions to suggest that this almost reflects a state of functional hypogonadism with undetectable gonadotrophin and androgens. Testes are small, and some boys actually have bilateral inguinal testes. Testosterone therapy in DMD, there are at least about 3 to 4 publications of its use. It certainly improves linear growth, but only to a mild degree, and certainly not the impressive 15 to 20 centimeters during puberty that we see in healthy adolescents. This study from Dr. Zacharin's group in Melbourne shows that in a group of boys with DMD treated with testosterone, that in fact change in bone density prior to testosterone therapy was negative, but after testosterone therapy, that there was an increase, there was a positive increase of BMD. So certainly there's some evidence to suggest that it's well tolerated, it does improve growth to some degree, and seems to perhaps increase bone accrual with time. Monitoring of puberty is recommended in the new standards of care from the age of 9, but perhaps it's not as realistic and certainly should be performed from the age of 12. It recommends the use of testosterone therapy from the age of 14, building up over a period of a few years and taking off at the end of virilization to perform biochemistry. Certainly some men on glucocorticoid, particularly daily glucocorticoids at the end of achieving virilization, may have low or borderline testosterone levels, which necessitate ongoing treatment with testosterone even in adulthood, with implications for transition and adult care. So I have given you an overview of the bone osteoporosis, puberty, and secondary adrenal insufficiency. Not have time to talk about growth failure, short stature, certainly of obesity, and metabolic consequences. And as you can see, boys with DMD or steroids is almost like a chronic state of untreated Cushing's, and it certainly requires work between the different specialty managing such boys and men. Implementing standards of care is important, and certainly in the UK and in the Netherlands, I know there are groups which involves close working relationship between patient groups and clinicians and academics to look into how we can implement these standards of care nationwide. In the UK, this is delivered by a project funded by Duchenne UK and the North Star clinical network, where within the endocrine working group we have teased out the priority areas that we want to implement in the UK from the 2018 recommendations, developed some patient information leaflets on secondary adrenal insufficiency and delayed puberty, and developed an emergency bracelet, steroid bracelet, with a link to all DMD emergencies for patients to order free of charge, and also held a couple of online webinars in this area. And I know in the Netherlands, similar projects have also occurred. So in this bit of it, I think I've finished my my talk on the standards of care. And here I would like to invite Eustace, and Eustace will share with you his experience, tell you a little bit of his life story and some of his experience on some of the aspects that we talked about. And Eustace, are you online now?
Yeah, there I am. Hi.
Right. So thank you very much, Eustace, to join us on this section. This is in fact your idea of doing it sort of a conversation or an interview. And so thanks very much for joining us. So Eustace, would you like to tell everybody a little bit about who you are, your age, done, and hopefully some people can see some of these nice photos of yourself, Eustace.
Yeah. So hi, I'm Eustace Skyer. I just turned 30 last September, and I live in Amsterdam. And as you can see on the left side, I graduated from the Delft University of Technology about 3 years ago. And yeah, I just had my birthday, but spread out over a month due to Corona to make it Corona-proof. So only like 2 people visited every other day or something, every day, making it Corona-proof. Yeah.
So that's nice, isn't it? You had 30 days of birthday celebration with small number of people visiting you.
30 years, 30 days, yes.
So let's start at the very beginning. These are just like such cute photos of you when you were quite young, isn't it? So could you tell us a little bit about, and obviously I'm sure you can't remember, but your family would have told you about your early years of how it led to your DMD diagnosis.
Yeah. So I was diagnosed at 2 years old and started with prednisone at the age of 4.5. Yeah, I can't really remember, but I think it was because my mom herself thought that I looked really playful, wanted to play with other kids, but kind of couldn't. And then she also had not Googled, but looked in a dictionary because it's so long ago, or in a medical dictionary to find out what thick calf muscles, if this might be something specific. Yeah, then it turned out that I had Duchenne muscular dystrophy.
So it sounds like you say you were on prednisolone. I think you've been on 10 days on, 10 days off since about 4 to 5 years of age, and you're still on that now?
Yeah. Yeah, so I've always been taking intermittent steroids, 0.75 milligrams per kilo. And I think maybe, I stopped at, I keep taking like 40 milligrams, I guess. Yeah. But
So
I've
that's
always taken it intermittent. Yeah.
So that's probably approximately, given that you're 30 and you start at the age of 4 to 5, that's over 25 years of intermittent steroid, and you're currently on 40 milligrams, isn't it? And that's useful for people to kind of put in context when we talk about some issues sort of late. And you're quite good in health currently with your chest and your lungs. You don't, and you're feeding. And in what age did you need to use a chair full time?
I think about 10 years old, 11.
Yeah, so about 10 years.
Yeah, and you can see that on the first picture where I'm little in the buggy thing. You can see that even when I was little, I already wasn't that strong because you see I can't even keep my head up straight
That's
all
right.
the time. And now,
yeah. So we're going to skip a little bit and go into adolescence, and we're going to talk about puberty. And this is a photo of you, a friend, and other people. This is some kind of a holiday, I assume, isn't it, Eustace? And I think you're about 15 in this age.
Yeah, this was a high school camping trip, and this was the other guy in the wheelchair at my school, so we went there together. Yeah.
So could you share with us what your story about your about puberty? So it seems like I understand around the age of 15 that you decided, you told your family that you want something done. Do you want to share with other people?
Yeah, I think you can already see here that I was 15, but I still look kind of young, maybe 12-ish, something. And for me, throughout my whole life, I've always tried to do everything as normal as possible. I think it's also, my mom has always taught me like should just try whatever you can, which you can do as normal as possible. And the things you really can't, you really can't. But I think this was something that I thought like, first I didn't really care a lot. Then I thought, but at 15 years, most kids look differently. So then, now it's time to do something about it. To be as normal as possible again. And I thought the solution was quite easy peasy. although we had to go to we had to find an endocrinologist ourselves, so it wasn't monitored or looked after anyway. And then I just had IM injections through our GP. So like I'm not sure it were like a few in a few months. I mean it's already 15 years ago, so I can't recall exactly, but yeah, as long as it was a problem with a quite easy solution. So yeah.
So so it seems like you've decided at the age of 15 you want your puberty to be addressed. And
Yeah.
am I right to say that before that this was not checked in your usual clinic appointment?
No, not that. No,
No.
not that I
Did
can
you have,
recall it now.
no? Did you have any side effects from the testosterone treatment at all, Eustace?
No,
No. Okay.
I can't really
You can't.
remember. I thought maybe I got a bit tougher than before. I was a bit more sooner scared or
Yep.
something. I don't know. Something like
Yep.
this maybe, but no bad
Yep.
side effects really. No.
Yeah. So certainly it's useful to know that now the new standards of care recommend we should be checking these things and not
Yeah.
waiting for things
No, I
to
think
progress.
it's a good thing. I mean, if you already got Duchenne's, where it's still quite hard to solve, then I think you should try to solve every problem around it probably as soon as possible, right? Or
Yeah.
when someone is ready himself for changes or
Yeah.
whatever. Yeah.
Then let's get to a few years down the line and talk about
Mhm.
something which I addressed in the talk. So it looks like I think maybe as you got a little bit older, you had some chest infections sometimes, which you're okay, you stay at home. But I think maybe in your 20s, around about this sort of an age, you probably had something that was particularly bad, isn't it? So do you want to tell others what happened and in relation to, I
Hmm.
suppose, the steroid stress dosing issue?
Yeah. So normally when I had like a chest infection, um, we could just solve it by taking oral antibiotics at home. But this time, yeah, it got more bad, and I had to go to hospital. And um, I just discussed with my mom how it went, but I think there we did mention I had to take a stress doses, steroids, and I think that was also something which wasn't really, in my case, hard to convince everybody, anyone of that this had to be done. But yeah, I went to the ICU unit, so I think probably they're also more used to using this. So I think that makes it. I'm not sure what happens if you go to a normal, I say it, normal part of the hospital with a bone fracture or whatever. They should take it. I'm not sure what would happen then. But for me, that went quite well. Yeah.
Yeah, yeah. So it sounds like, from what I understand and speaking to your mum, you were particularly ill this time and in fact needed to be
Yeah.
ventilated. But it was your
Yeah.
mum who actually suggested that perhaps stress dosing it should be considered, isn't it? And I
Yeah.
think some sort of
Mhm.
like you said, maybe having the
Yeah.
information in in
Yeah. I
files
think
is
that was also when I started using my, or I got my first ventilator to use at night. And I think the pitfall was a bit that,
yeah,
yeah, that I had just not started yet with home ventilation. Well, maybe if I would just have started, I don't know, about a year earlier, half a year, maybe it could have made a difference. But
yeah,
yeah,
yeah.
I'm not sure.
So let's move to well, the next section, which
Yeah.
well, the title so talks about it, and I think you were
Yeah.
probably in your mid-20s and you developed really bad back
Yeah.
pain. Can you just tell
Yeah.
us about that
Yeah.
episode?
So I think it was even before. So first I had this problems with my vertebrae before the chest, the real bad chest infection, I guess.
Yeah,
But yeah, that just started like at once, I think. I'm not sure. It was when I one time just bent forward because I first used another wheelchair, like a more manual wheelchair, you could sit up more straight. And then I bent forward and once sitting on my bed. And then at once I just felt my back in terrible pain. Um, yeah, and I think the back pain has at least then changed my life maybe the most, because I used to use like a semi-manual wheelchair, which I prefer to a bigger electrical wheelchair. And here you can also see that. So I'm in this chair with a pillow behind my head, because it was just because this was the chair I could use, the only one I could use, which is actually a sports chair, so not really fitted for me. Yes, I think having back pain is really the biggest problem, maybe because I ended up in this wheelchair where you can see my arm is on the armrest all the time. So I also lost quite a lot of arm function and hand movement. And yeah, all just because of what happened to my back. So yeah,
Yep.
I think it's
And
really important, something to address. Yeah.
And as I understand, Eustace, it took a while for the diagnosis because there were some people who weren't quite sure that you will be
Yeah.
able to get vertebral fractures. And I think
Mhm.
what I discussed in the talk is that people on intermittent steroids,
Yeah.
vertebral fracture is less frequent, but certainly it can
Yeah.
happen, right? Which it did
So
happen with
in
you.
my case, it did happen. Yeah, and I think the first time it took about 4 months or something before I had the first regular X-ray done for
Yeah,
this, and then I had like a few collapsed
yeah, yeah,
vertebrae, but then I had to take quite a lot of painkillers. So
yeah,
tramadol I took quite a lot,
yeah,
but I still went on studying, because this was like I think my second year in Delft of studying. So yeah, I
yeah.
had to go on, but I did manage on the painkillers, but it's not something you want anyone to have now.
That's right. And
Yeah,
you receive some bisphosphonate infusions, and they seem to help with pain. And you've
yeah,
been receiving it roughly on an annual basis. But the bit I want to now talk about is probably about 18 months ago, kind of thing, isn't it? Where you seem to be basically pain-free, or you don't have severe
yeah,
back pain. And
mhm,
then something happened again. Do you want to tell us
yeah,
this last bit of
yeah.
the
So maybe on
experience?
about the first time as well. I first got I think it's called the denosumab infusions, with only when the first time I had this, so like about 10 years ago or 8, and then it was with the run-in time, infusion run-in time of about 50 minutes, and then I really that night really got ill, and now I get the Somata or something similar, and that works much better for me and has less side effects. But the other other cry over vertebral fracture crisis was, I think, now a year ago, so not this December but before, right before the corona crisis. Then we lifted me onto my shower chair, and at once I could just feel the same kind of pain in my back. But then which is logical. I had to go to hospital first to really have it checked whether or not it was my bone fracture, but I could already feel it. So I think I could have stayed home and just started with the infusions. But yeah, you have to check it right. And then first they just made a lateral X-ray of my back, and they almost sent me home. But the lucky thing is I have a endocrinologist friend from abroad, right? And so we discussed in hospital. Then they also made a CT scan while they were at the point of sending me home. And then they could see a fracture. So that was lucky for me. But for other people, it should be clear that I think you could just probably skip the X-ray, because it only took time. I had to be in hospital for like a whole day. So
Yeah,
next
so I
time
think
is also better.
Eustace, from what I understand, I think you went to emergency and they did a lateral spine X-ray, but they couldn't see any new fractures. You were in a lot of pain, but they thought that the views were very poor. And in fact, actually, a
Yeah,
CT scan showed that there was a completely new
yeah,
fracture in the previously normal vertebra. So it just shows that sometimes,
yeah,
particularly in older people, at least in my
yeah,
experience, if views are not particularly very good, we need to consider other forms of imaging. And I think that's kind of a useful
yeah,
lesson for all of us, isn't it? So Eustace, I suppose maybe this is where we see pictures of you with all your other friends in university, and whether
all the
you've got
guys who
any
helped me,
last message.
Any last message? Yeah. So I think it's good for people with Duchenne to try to do everything as normal as possible. So I think it's good to try to solve like everything you can around the Duchenne itself. Yeah, and in my case, quite most of the things we had to figure out ourselves. So I hope with new guidelines also for other people, it would be, yeah, we could spare them this, let's say, make sure they don't get not all the problems I had. And I think it's important, yeah, for physicians and doctors to also listen to patients well, right? Not decide for them, just have them decide themselves what they want. And also, yeah, in my case with the vertebrae, I could really feel there was something bad, and it turned out for me to be right. That might not always be the case, that what your view is exactly what has happened. But in my case, it did. So, yeah, I think that would be it.
So thank you very much, Eustace, for your very nice story. Lots of lessons for us.
I hope it was helpful.
It is.
Yeah.
Thank you very much, Eustace. I'm sure there'll be questions for you. And I just want to finish up by sort of saying I think there are still lots of other issues for consideration, particularly of adult care, some of which Eustace has actually raised in his story, and some of the issues that I've raised, and I think that certainly needs more thoughts. And with this, I just want to thank a lot of people in Glasgow, Scotland, UK, and internationally, particularly Dr. Shuko Joseph, who did a lot of the work that I presented today, and also colleagues in the neuromuscular team and Endocrine in the UK, and patient representative, particularly Alex Johnston from Duchenne UK, but also Elizabeth through the Duchenne Parent Project Netherlands and World Duchenne Organization, who actually helped shape this talk considerably. So thank you very much, all of you. Thank you to Eustace. And I'll be happy to take some questions now.
Yeah.
Thank you, Jared. Thank you, Justice, for the excellent talk. We received already some questions. Jared, did you see it in the question box?
So I think there's a question from Erica, which asked about why IV bisphosphonates are not oral. So oral is not contraindicated, but based on some evidence from studies in osteogenesis imperfecta, not randomized studies, where oral bisphosphonate has a lower bioavailability in children, does not improve the shape of vertebral fractures, although IV bisphosphonate does. Bearing in mind that lots of these boys also have gastritis, and a GI side effects on oral bisphosphonate is also fairly common. So it's not contraindicated, but it's perhaps not the best agent to commence in the first place. Any other questions? So I think Farasat. So Farasat, thanks for your question. So about vamorolone. So vamorolone is a dissociative steroid, which is currently under clinical trial with its results expected in the next 2 years. So it has properties of steroids. So it's thought to have the anti-inflammatory properties, but not the steroid side effects. I'm not involved in the clinical trial. It seems a very promising agent, and I think we need to see what the results of that trial shows. And if, yeah. Sandra, any other questions? I don't think I see.
Yes, we have a live question from Miriam Franca. You're unmuted. You can ask your question.
Oh, no, sorry.
Okay, no problem. Okay, there. See if there's some more questions. You can ask your question via the chat box, or yeah, we just received another question, Jared, via the chat box again.
Do I admit patients receiving bisphosphonates to the hospital? I don't have a hard and fast rule. I think for first infusions, you mean. I previously did, although over time I have not. The first infusion steroid side effects includes fever, aches and pains, sometimes vomiting. It can sometimes occur 3 to 4 days after the first infusion. So I've stopped admitting hospitals routinely because previously we used to admit for 24 hours, but counseling families about stress dosing and when to present to the hospital. So not routinely, but I have considered if families feel that that's safer for them and for reassurance.
I'll just see if we have received some more questions. Moment, yeah. There's a question via the question box from Saskia Houwen. Jared?
So Saskia, hello Saskia. So the contribution of DMD on bone development and the contribution of glucocorticoids. So look, Saskia, fractures have already been reported with steroid naive boys with DMD. So certainly the underlying muscle weakness can contribute to poor bone development. We know long bone fractures, particular fracture of femur is also very common in steroid naive people. Vertebral fractures are much less common in steroid naive boys with DMD. So I certainly think that their dual contribution and taking away steroids, you probably will still see a certain amount of long bone fractures.
And I also think that I forgot to tell that about the age I got wheelchair bound. I also started using long leg braces and calipers, which together with the steroids probably have also ensured that my back is still quite straight and strong, and my legs have been strong also. So I'm not sure if I hadn't taken the steroids, if my back would even be worse because of the disuse probably.
Yeah. So I think there's another question from Iran about the dose of testosterone. It's very variable between lots of endocrinologists have their own recipe of what they do. I give a choice between topical testosterone and injectable testosterone. There is a clinical trial on a escalating dose of testosterone in DMD published by the Newcastle team. So if you don't have a recipe, you could look into that because there's published data. Andre, hello. So the experience of continuing bisphosphonate treatment in adults with DMD. So this is an interesting question, and I think there's still no evidence. One needs to be careful about long-term use of bisphosphonate because whilst certain side effects like osteonecrosis of the jaw have not been seen in children, but I do have some concerns if we use bisphosphonate for long periods of time well into adulthood. Does the transition work well? It's we do have some system of linking in with an adult bone specialist, and how is treatment managed in adults? I think unclear, and I think there is a case to perhaps consider in those with vertebral fractures, bad vertebral fractures in adulthood, to consider giving a break of bisphosphonate and transitioning to an anabolic agent like teriparatide, for instance, which my adult clinician seems to favor, but there's little data. So yeah, an area where perhaps some guidance is useful.
Yeah, and I think I made a mistake when we discussed my first bone fracture. Then the first bisphosphonates I got was palmitoronate, and that was the one which gave me like a bad fever and also how do you say it, inflamed artery on my arm as well. So yeah.
Sandra, can I take one more question?
Yeah, you may, if you're available still. So.
Yeah, Guido asked about romosozumab treatment in these patients. So certainly romosozumab is an anabolic bone protective therapy. It's a sclerostin antibody. It does seem to have some anti-resorptive therapies as well. It has been studied in adults with osteoporosis, never used in children. So certainly clinically, I am not sure, I don't see a clinical use of that. It certainly is an agent that is very useful to explore in this context, because I think an anabolic bone protective agent is what boys with DMD need. Can it be used in adults is the question, but certainly not in pediatric patients. But I think research is needed and potentially may be better than bisphosphonate therapy.
I think, Gerard, we covered all the questions for now. Do you want, before we wrap up, say anything
Yeah, so thank you very much to the ERN, Sandra, and to Eustace and all of you again. Hopefully you found it useful, especially listening to Eustace's story, and thank you very much for your time.
Okay.
Thank you.
Thank you, Jared, and thank you, Justice, for this excellent and valuable talk today. And thank you for all to joining the Endo-ERN webinar today. And I wish you all a nice day. Thank you.